I'm Peter Block, and with me to my left is Chris Cannon from the Brigham and Women's Hospital. And I'm going to start this interview by saying the times they are changing, or maybe I should say the diabetic treatment times are changing. Chris happens to be an expert in multiple things, including this whole business of new diabetic therapy. So Chris, tell me first off about the new drugs very quickly, and then let's talk about the pleiotropic effects here of these new drugs, which is the exciting part. And lastly, how we deal with this in terms of how we best care for our patients.
Well, it's a very good point. I am definitely not an expert, but I think with the new data, we all need to get up to speed. And so I'm trying to catch up and learn, because what we've seen is there are two classes of drugs that have reductions in cardiovascular events and cardiovascular mortality over and above the glycemic control factors. So the ADA recently gave preference to using those agents early on and in the management. So the SGLT2 class is a very interesting one. It blocks glucose uptake and to urinate out extra glucose, but then has lots of other effects. You lose weight, it protects the kidney with changes in the glomeruli, so really nice other effects. It helps reduce blood pressure, and that may be part of how this translates into benefit. The other class are the GLP-1 agonists, and the LEADER trial showed a benefit as well. And so amongst all the different drugs, we have to start picking and choosing. And as cardiologists, I think we feel that we want to provide that cardiovascular protection, but that's sort of different. And how do we do that? And we haven't managed diabetes.
Exactly. Let me interrupt, because I always think about myself when I discharge a patient. You say, oh, please take care of his diabetes, but somewhere else, right?
Yeah, it's a very tricky thing, and patients will, by the time they land in our lap, often have had diabetes for 5 or 10 years, and so someone's been managing, and yet we want to participate. And so one of the concepts that's being talked about is sort of creating more dialogue between the endocrinologists, primary care, and cardiologists. Not that we want to take over, but really to discuss which would be good medications. You know, reductions in heart failure have been seen in the EMPA-REG study with the SGLT2 class. We see a lot of diabetics with heart failure of various degrees, and so to get that discussion going beyond just glycemic control to weave in cardiovascular prevention.
Yeah, and throw in renal failure, because that's not a minor issue, and the renal folks are sort of over there, right? So all of a sudden we're talking about a team. It's sort of a simile to the heart team, but a little different, isn't it?
Yeah. Well, the communication, ironically, is very difficult, despite our electronic records and things. So opening up new dialogue, and we've done this with dual antiplatelet therapy, with again the primary care for duration. Cholesterol management, what's the target? So we now have to engage in a discussion in managing diabetes, and we have plenty to learn too from the endocrinologist, and so I think it'll be a good dialogue too.
I think that's absolutely right, Chris. One of the issues is practically, of course, like everything else, when the rubber meets the road, how do we actually do this? But my guess is there's going to be a fair amount of emailing back and forth and electronic record passage from specialist to specialist. So who's going to be the kingpin? Who's going to control all of this, do you think, Chris? Is it still going to be the internal medicine fellow or guy that is the main guy?
Well, I think so, because diabetes management is complicated and a long-term factor, and I think the role that we may play is helping choose which classes, but then co-participate. I think the other part in managing diabetes is, and has been discussed, all the other things. So to remember to get to the diabetics on statins and ACE or ARB and antiplatelet therapy when appropriate. And very often all those other things also need a little bit of attention. So there's room for really good partnership in managing glycemia, but also managing cardiovascular risk.
Okay, so I think the take-home message for all the folks out there who are starting to learn about these new drugs and learn about their pleiotropic effects is, yes, we have a lot to learn. We are going to be a partner in this, whether we like it or not, which is appropriate. And in the long run, guess who wins? The patient. Thank you, Chris.